My name is Horacio Kaufmann. I'm a professor of neurology at New York University, and my specialty is the abnormalities of the autonomic nervous system. The autonomic nervous system is the part of the brain that controls everything that is involuntary, like the blood pressure, the heart rate, the gut, the bladder, sweating, everything that doesn't require a conscious decision. That's why it's called autonomic or autonomous. In Parkinson's disease, the autonomic nervous system is very, very frequently involved, and the involvement of the abnormalities of the autonomic nervous system are an important part, a crucial part of the disorder. The most common and most dramatic autonomic abnormality in Parkinson's disease is a fall in blood pressure upon standing up. That's called orthostatic hypotension. And why that happens? You see, upon standing up, because of the effect of gravity, there's almost 1 liter of intravascular volume that is displaced to the lower part of the body. This is a big challenge to the circulation because the brain is above the heart. So to get the blood not only back to the heart, but from the heart to the brain, that requires a complicated response of the autonomic nervous system. And that response is abnormal in patients with Parkinson's disease. So what happens? What happens is that upon standing up, not enough blood gets to the brain, and patients have the feeling of lightheadedness, a sensation that they could faint, blurry vision, or even more non-specific symptoms like fatigue or tiredness. Now, it's important to realize that this can be treated, but of course, to treat this, the sine qua non, the necessary step is to diagnose it. Now, for diagnosis, of course, the symptoms are important, but what confirms the diagnosis is just something as simple as measuring the blood pressure and the heart rate with the patient sitting or supine, and repeating that again after a few minutes of standing. By definition, we call orthostatic hypotension a fall in blood pressure of at least 20 millimeters of mercury systolic. Now, it's important to realize that although the pressure may fall, if it doesn't fall too low, there may not be symptoms. So this should be treated only when the patient has symptoms, meaning when there is cerebral hypoperfusion. And that usually occurs when the systolic pressure standing is around below 90 or 95 millimeters of mercury, because it's at the lower limit of what the brain can tolerate in what's called autoregulation. How do we treat this? There are a number of ways to treat it. Number one is very important to review medications. There are a number of medications that can either produce themselves or worsen orthostatic hypotension. The most common is anti-Parkinsonian drugs, particularly dopaminergic agonists that will lower blood pressure even more than levodopa. In addition to these, there are a number of medications. The most common offender probably is alpha adrenergic blockers, which are drugs used for prostatic hypertrophy. And why that happens? Because although they open the bladder wall, they do the same thing with the blood vessels. They open the blood vessels, so they lower the blood pressure upon standing up. So it's important to realize that those drugs should be discontinued. So the second step, after making certain that medications that can worsen orthostatic hypotension have been discontinued or changed, there are a number of non-pharmacologic measures that can be quite effective. Number one is important to increase the amount of salt and water in the diet, and remember that because of the effect of salt or sodium on blood pressure, most Americans, elderly Americans, are aware that they shouldn't take in too much salt. Now, of course, if somebody has orthostatic hypotension with Parkinson's disease, it's very important to increase the amount of salt in the diet and also the amount of water. The second very effective measure, something that has been known for a long time, is to raise the head of the bed at least 30 degrees. And why is that? What does that do? It's important to recognize that the fall in blood pressure is one side of the problem. Usually the second side or the other face of the problem is that the pressure, when the patient is flat or supine, laying in bed, the pressure is too high. So it's very low standing, but it's quite high when they are flat. And what are the consequences of that? The consequences are that because the kidney is a filter, when the pressure is high during the night, there is an excessive loss of sodium and water overnight, and that results in severe intravascular volume depletion, meaning dehydration in the morning, that worsens the fall in blood pressure in quite a remarkable way. So just by raising the head of the bed, the pressure falls during the night and there's less sodium and water loss, and the pressure in the morning doesn't fall as much as if the bed is flat. So very important to use either a wedge or one of these new electric beds that allow you to raise the head of the bed. There are also a number of simple maneuvers that can help orthostatic tolerance, and that is standing on tiptoes, compressing the buttocks, and even the hands. Why? Because that helps, there's a muscle pump, and that helps bringing the blood back to the heart and from there to the brain. These simple measures usually improve things, but not all patients, this is not enough for all patients, and there are a number of patients that still require something else. So after non-pharmacologic measures, if symptoms are still present, we can use drugs. Using drugs there are two strategies. Number one is to increase intravascular volume, and number two is to increase peripheral resistance of vasoconstriction. A simple example is to think about the hose in the garden. If you want the water from the hose to go further, you have two alternatives. You can open the faucet so that more water comes in, and that will be the equivalent of drinking more water and salt, or you can press your fingers on the hose so that the water goes further. Pressing the fingers is the equivalent to producing vasoconstriction. Now, how do we increase intravascular volume? The common drug is fludrocortisone. Fludrocortisone is a synthetic mineralocorticoid. It is a drug that reabsorbs more. It helps absorbing sodium and water in the kidney. It's quite effective, although it's not approved for this indication, but the problem is that it has a number of side effects, particularly in the long term, like heart fibrosis, or it can accelerate kidney problems, and produces also a big increase in blood pressure supine. So it should be used very cautiously and no more than 0.1 milligram a day, meaning one pill a day. The second strategy, as I mentioned, is to use vasoconstrictors. There are two vasoconstrictors that are approved by the Food and Drug Administration. One is called midodrine. This has been around for almost 20 years. It's a direct adrenergic agonist that, after taking it, produces vasoconstriction in around 45 minutes or an hour, and the effect lasts for a few hours. The second alternative is a newer drug that was approved less than 2 years ago by the Food and Drug Administration in the United States, and this is called droxidopa or Northera. What is it? This is a precursor of norepinephrine. Is an artificial amino acid that, after taking it by mouth, is transformed in the body into norepinephrine. What is norepinephrine? Norepinephrine is the messenger, the transmitter that the sympathetic nerves use to produce vasoconstriction. And is this neurotransmitter the one that is deficient in Parkinson's disease and is the one responsible for orthostatic hypotension? The deficiency of this neurotransmitter is responsible for orthostatic hypotension. You see, there are a number of neurotransmitter deficiencies in Parkinson's disease. We're all aware of the dopamine deficiency that explains the motor deficits. The autonomic deficits are due to another neurotransmitter deficiency, that is norepinephrine. The interesting thing of droxidopa is that it replenishes the body of this neurotransmitter that is deficient. It works in around the beginning of the effect is around an hour after taking it, and it continues, the effect continues for 4 or 5 hours. In the 3 big trials that resulted in the approval, the 3 clinical trials that resulted in the approval of the drug, they were around 80% of the patients, of the around 500 patients that participated, 150 were patients with Parkinson's disease. And in these patients, there was a significant improvement in symptoms, standing, which is what the Food and Drug Administration was interested or demanded, that we had to show that there was improvement in symptoms, and the secondary outcome was an increase in blood pressure standing that was also fulfilled. There was an increase of around 10 millimeters of mercury systolic with the patient standing. So the drug resulted in improvement in symptoms and improvement in blood pressure. So let me somewhat summarize what I tell you to emphasize that orthostatic hypotension is a very common problem in patients with Parkinson's disease. Symptomatic orthostatic hypotension, meaning symptoms of lightheadedness, dizziness, or the sensation of fainting, may occur in between 16 and 20% of patients. And the crucial thing is that if it's diagnosed, it can be treated, and it can be treated quite effectively with non-pharmacologic and pharmacologic strategies that result in very significant improvement in quality of life.